Welcome to Medical Education Principles Lesson 1, The Neuroscience of Learning, Rationale for Guided Experiences. This is David Lee Gordon, Professor of Neurology. At the end of this presentation, the participant should be able to explain why seeing a high volume of patients independently does not lead to learner growth or expertise, and describe the importance of didactic teaching in optimizing experiential learning. There is a common misconception in clinical medical education. Many medical teachers do not realize that providing experiences without learner preparation or feedback actually has negative consequences on learner education. It leads to missed learning opportunities, does not lead to learner growth, may lead actually to learner regression through inaccurate experience interpretation. We call this interpretation bias. And it increases learner anxiety. Thus, practice alone does not make perfect. Seeing more patients does not lead to competence and expertise. And competence criteria for credentialing providers based on patient volumes are flawed. In order to understand learning, one must understand memory. Memory is the cognitive process of acquiring and retrieving information and experiences. That's learning information, remembering information, learning experiences, and retrieving or remembering experiences. And this process involves many parts of the brain. There are three main parts of the brain involved with learning and memory: the limbic system, the cerebral cortex, and the basal ganglia and cerebellum. The limbic system consists of the primitive structures in the middle part of the brain. The amygdala and hypothalamus work closely together, the hippocampus and thalamus work closely together, and the basal ganglia and cingulate gyrus work closely together. And the limbic system processes memory and emotions. The cerebral cortex is the evolutionarily newest outer layer part of the brain, and it processes higher order cognitive function, and it stores acquired memory fragments. So, for example, if you have an experience, it may be processed through the amygdala with help from the hypothalamus, but when you store those memories, different components of the memory are stored different places. The smell during the experience is in the olfactory memory area, and the visual phenomena are in the vision memory, and the auditory memory in a different place, etc. This is why folks with, for example, Alzheimer's disease. So people with Alzheimer's disease first lose their hippocampus and medial temporal lobes, amygdala area, as well as hippocampus primarily. So new memories can't come in, but the old memories are stored somewhere else. So they remember things that happened years ago, but they may not remember what they ate for breakfast because the new memories aren't being laid down, but the old memories are stored somewhere else. So one of the roles of the cerebral cortex is to store these acquired memory fragments. But perhaps almost more importantly in some ways, the cerebral cortex creates new memories via reasoning. So you don't even have to have experienced something to think you've experienced something. The brain has the ability to create its own memories through the cerebral cortex. Now, why would it do that? Well, first of all, this facilitates learning from others. When you hear a story told to you by somebody else, case-based learning in medicine, or reading from some famous book of stories and morals, it's as if you've had the experience when you really didn't have the experience. You are able to do that because the cerebral cortex creates these memories, as it were, from other people's experiences. It also enables human beings to have empathy. You can literally feel the experience of something without having experienced it. That's what empathy is all about. It also enables folks with psychological trauma to survive better. You can be in denial and in essence change the experience in your brain. And for the purposes of learning specifically, this ability to create new memories allows you to integrate experiential and factual memory. perhaps your experiences are not in line with what happens most of the time. Well, if you know what happens most of the time, you can rationalize what happened with your experience and combine those into one integrated memory. The basal ganglia and cerebellum are primitive structures in the middle part of the brain as well as the limbic system, but they control speed and coordination of motor function. So we won't be discussing this much here, but those parts of the brain help with skill acquisition. So for example, if you are learning to intubate or put in a line or medically, or if you're playing a musical instrument or playing a sport, at some point, having done it multiple times, you don't want to think about what you're doing. It comes an autopilot, as it were. And that's what the basal ganglia and cerebellum enable you to do these physical activities on autopilot. There are 4 memory subtypes: experiential memory, factual memory, reasoning memory, and motor skill memory. Experiential memory is acquired via experiences, and it has attached emotions. And it's processed primarily through the amygdala, facilitated by the hypothalamus in the autonomic nervous system. Experiential memory facilitates mental shortcuts and automatic behavior. Factual memory is acquired via external sensory stimuli, such as vision and hearing. Vision, reading materials, seeing a video; hearing, listening to a podcast, listening to a lecture, listening to a video. And the processing center is primarily the hippocampus, and it's facilitated by the thalamus. This facilitates book learning, as it were, and knowledge acquisition. Reasoning memory is acquired via self-awareness, reflection, insight, and foresight. It is cognition across time and integrates the other memory types, and is processed through the prefrontal cortex, and it facilitates rational behavior and creates the new memories. And as we talked a moment ago, motor skill memory, acquired via repetitive movement, is processed through the motor cortex, basal ganglia, and cerebellum, and it facilitates skill expertise. Daniel Kahneman won the Nobel Prize in Economy for his concept of thinking fast and slow, these 2 thinking systems, 1 and 2, in regard to economics. But this concept has a much broader application. Kahneman describes system 1 thinking as fast, automatic, emotional, subconscious, no voluntary control, and used frequently. What is he talking about? In essence, he's describing experiential memory, which is processed through the amygdala and creates these mental shortcuts or heuristics and biases. He describes system 2 thinking as slow, effortful, logical, conscious, concentration and choice, and used infrequently. What is he describing? In essence, he's describing reasoning memory, processed through the prefrontal cortex with awareness. Kahneman emphasized that we often think without thinking, especially system 1, which is subconscious. We're not aware of what we're actually thinking. He says we can be blind to the obvious, and we are also blind to our blindness. The first person that I know of who said experience is the best teacher is the ancient Roman Gaius Julius Caesar. Benjamin Franklin, the famous American, said, "Tell me and I forget, teach me and I remember, involve me and I learn." And Will Rogers, a famous Oklahoman, who was perhaps a bit sexist, said, "There are 3 kinds of men: the ones that learn by reading, the few who learn by observation, and the rest of them have to pee on the electric fence for themselves." So all 3 of these folks made it clear that experiential learning is effective. If you experience something, you remember it. It is equally important, however, to understand that experiential learning is insufficient on its own and in fact can be misleading. Benjamin Franklin also said, "Experience is the best teacher, but a fool learns from no other." W. Edwards Deming, the godfather of quality improvement in this country, who went to Japan after World War II and helped their companies become efficient, wrote, "Experience itself teaches nothing," and he emphasized the word itself. The famous physician, Sir William Osler, wrote, "The value of experience is not in seeing much, but in seeing wisely. The famous football coach who won the first 2 Super Bowls, and now the Super Bowl trophy is named after him, said, "Practice does not make perfect. Only perfect practice makes perfect." And the essence of all this is a concept called deliberate practice, developed by Anders Ericsson, an educational psychologist. And he wrote, "Living in a cave does not make you a geologist. Not all practice makes perfect. You need a particular kind of practice," what he termed deliberate practice, to develop expertise. In fact, experiential learning may lead to adverse effects when unguided, as exemplified by this study. Seeing more patients led to lower test scores in University of Michigan neurology clerkship students. Investigators reviewed patient logs of 212 students in one academic year. They determined the number of patients each student saw in 5 diagnostic areas: seizure, headache, stroke, acute mental status change, and dementia. They compared the number of patients seen by each student with the student written exam scores, including the 5 diagnostic area subscores, and their clinical performance scores. The more patients a student saw in a given diagnostic area, the lower the student's exam subscore was in that area. And the total number of patients seen did not correlate with total written exam score or clinical performance score. How do you understand this? Interpretation bias explains these results. This is the tendency to analyze ambiguous information or experiences inappropriately. The bottom line is that experiential learning is valuable only with instructor guidance. As we've seen, experience results in effective recall, but potentially faulty learning if unguided. The good news is it leads to enhanced learning if guided. Unguided experiences without preparation, feedback, and reflection, led by an instructor, for example, the use of patient logs, does not lead to meaningful learner growth. While guided experiences with preparation, feedback, and reflection led by an instructor, for example, in a simulation exercise, does lead to meaningful learner growth. Let's look at an integration of knowledge and experience and its effect on thinking system and behavior. When one has an initial experience, one forms a shortcut, a mental shortcut called a heuristic, based on experiences and associated emotion-tagged memories processed via the amygdala. Then, when you have a repeat similar experience, you have an emotion with what's called somatic markers by Antonio Damasio. He calls these somatic markers warning bells. So these are emotions and autonomic nervous system symptoms in response to the repeat experiences processed via the amygdala and hypothalamus. You say, whoa, I have done this before. I have had this experience before. I recognize this. Now, this can lead to one of 2 paths of behavior through thinking system 1 or thinking system 2. If you have this repeat experience that you recognize and you have these warning bells or somatic markers, you may act reflexively. You may have a gut feeling or intuition triggered by these somatic markers via the amygdala, this experiential memory, that compels your fight or flight behavior. On the other hand, you may use a somatic marker to wake up your prefrontal cortex, to process reason, to open up thinking system 2, thought and awareness via the prefrontal cortex triggered by somatic markers, incorporating your book learning from the hippocampus, your factual memory, that compels rational behavior. So let me give you an example. If you have a patient who you give thrombolytic therapy to for stroke, and they bleed, the first time you ever see a patient, they bleed and don't do well, then your bias from your experience is to not want to give TPA. You will hesitate. But if you use your prefrontal cortex to realize that 95% of patients who get this medication in the proper way actually do better, then you'll overcome your unconscious bias with reason. On the other hand, sometimes you want to use thinking system 1. If you, for example, drive in a rural area where you see deer at dusk and you come to that area again during dusk, you automatically slow down without thinking in order to not have a collision with a deer. That's actually a proper use of unconscious bias. So both of these systems, 1 and 2, are appropriate in certain circumstances, and one must figure out when to use each. So optimizing experiential learning requires a synergy of instruction and experience. Didactic teaching optimizes experiential learning by enhancing learner preparation, confidence, enthusiasm, flow, which refers to skills acquisition we'll be discussing later, and accurate comprehension. And didactic teaching refers to not just lectures, of course, but also readings, essays, small group discussions, and simulation, including case-based learning, standardized patient simulators, and other examples of simulation. The crux of the matter, as well stated by Sir William Osler, is to study the phenomena of disease without books, is to sail in uncharted seas, while to study books without patients is not to go to sea at all. And clinical medical education is most effective with well-coordinated didactic and experiential curricula led by informed instructors. This concludes the first lesson of Medical Education Principles, the Neuroscience of Learning. I hope now you are able to explain why seeing a high volume of patients independently does not lead to learner growth or expertise. And I hope you're able to describe the importance of didactic teaching and optimizing experiential learning. Thank you for viewing and listening to this presentation. This is a DLG Insight production. Innovative neuroscience ideas and thoughts on education.